Let me ask a question to Dr. Jayaguma. Please come. You discussed about some techniques, imaging, laser, diamond shock waves. Is any of these techniques can be used as a replacement to stent or other techniques?
No, standalone they may not be useful. So most of the time, because by the complex nature of the lesion itself, you will have to stent them.
Yeah, because a lot of hype in the social media. Many people feel
I
that this can be used as a replacement to stent and all.
I think that the problem is most often with the laser. Now people are advertising laser as something which is like a magic bullet, which is absolutely untrue. It has got certain role. Actually, laser is not a new technology. It was introduced maybe about 15, 20 years ago, and only recently, because companies were promoting it, it catched up. It is not that it is entirely revolutionary therapy or anything like that. Because when you go to Calicut side, you will see a lot of hoardings on the roadside saying that it's a solution for all your problems. It is not like that.
So even if you're using laser, you may have to go for the other techniques.
Especially for laser, because for laser, the luminal gain is not as good as orbital or rotational atherectomy. So you'll have to.
So none of these are replacement. All these are adjoint tools for doing
Exactly.
Still, if necessary, you have to go for stenting and all. Yeah. Dr. Kiran, so finally, is TAVI going to replace surgical aortic valve?
No, I don't think so. As I said in the take-home message, both has its own space. In high-risk patients, definitely now, if you are able to do a transfemoral TAVR, then it has its own advantages. But in low-risk patients, younger patients, still you have only outcome data up to 10 years. So if you are doing in a 60-year-old person, you expect him to you data for at least for 20 years, which you don't have. So till now, at this point, I think it has its own space, both the surgical and IoT and the TAVR. And if in a very young patient, like less than 50 years, where you prefer a mechanical valve, you don't have an option for a TAVR. So definitely both coexist.
To add on to that, actually, TAVR has taken over a few of the surgical patients, and also the total number of aortic procedures has gone up because the inoperable group has been taken over by the TAVI group. And as a surgeon, I am worried about the long-term complications related to the crimping of the valve. So still we have to find out what is happening with that. Even though the companies come up with a study which shows a better valve survival and longevity, still there will be some problems. Which has
in fact, there's adding a point, there's a early TAVR study where they have done TAVR in severe AS patient who is asymptomatic. Till now, we have only indications for a symptomatic severe AS patients. Though they have done TAVR in a severe AS who is asymptomatic and compared with the medical management, they found that it was superior to medical management. So it is being tried in every subset of patients.
We are using this degenerative bioprosthetic material as the valve leaflet. So it can degenerate very fast. So we don't know.
Yeah, it can. But you have 10-year data. Yeah. And even after 10-year data, the valve deterioration in the Notion trial, it is better than a surgical aortic valve. But I'm not sure because this one trial, maybe you need more trials to give a correct opinion about it.
Once it degenerates, then once you put a TAVI, then after degeneration, going for a surgical replacement would be more risky.
I think then you will have to go for a valve-in-valve TAVR.
Then it will be difficult to preserve these coronaries and all when you are going for valve-in-valve. So it's always in a patient who is having a good if he is a good surgical candidate, no LV dysfunction, good longevity expected, still surgery scores over.
Definitely.
What is the price difference?
So the TAVR, the valve costs around 13 lakhs. So maybe altogether it will be around 14 lakhs. Surgery you can do in half the price. I think if you are doing in a valve-in-valve, I think the balloon expandable is more better than the self-expandable. And The other choice, depending upon the coronary ostium height and all, the coronary accessibility will be more better in balloon expandable valve than a self-expanding valve.
I have a question to Dr. Dr. Jai Kumar. So when we advise, suppose some patients we send for a bypass surgery, the patient's response is, why can't we do a laser things? So what is the cost of, suppose you do a plasty with laser catheter? What is the cost of laser angioplasty?
The catheter itself, you use it for a single use, it's about 2 to 2.5 lakhs. But I think the catheter is quite reusable. People have used it for more than 5 times without much of an issue. So cost will come down. But still, if it a replacement surgery, it's probably not, because none of these laser orbital atherectomy, none of these technologies have actually has shown any improvement in survival or any reduction in ACS events in future. They all exist because they can expand the spectrum of patients whom we can do angioplasty. But whether this will turn to benefit, long-term benefits, we don't know. So for surgery versus bypass, you will have to follow the current guidelines and
Dr. Nevin, this minimal access surgery and non sternotomy surgery that is available in Thrissur.
Yes, we can do.
Is there any head-to-head trials, anything in sternotomy and non-sternotomy?
No, actually, it is the difference is just in the access. Whatever we do inside is the same. It is just like doing an open or lap cholecystectomy.
Okay, so the patient will be able to back to their routine.
Yeah, in 2 weeks. If you do a sternotomy, it will take usually 6 weeks for the bone to heal. But the patient can start walking even the next day of the surgery. It doesn't matter whether it's sternotomy or MICS. But the healing process will take little more time. So the patient has to avoid straining and all. But in the minimal access, there is no involvement of cutting of bone. So patient can have a life back to normal within 2 weeks.
So when it is minimal access, is it possible to go posteriorly and graft RCA?
Yeah, exactly. But what I showed was a grafting to a PDA.
Any questions from the floor? Yeah, then we'll conclude the session. Thank you all the speakers. It was wonderful.